Hello, everyone, and welcome to this new episode of the Hormone Replacement Therapy for Women podcast with Angie Nichols. She was introduced by hormone optimization therapy expert Dr. Neil Rousier in episode 1 of this series. If you haven't already, please subscribe to my channel by hitting that red button and notification bell so you won't miss anything. So, together with many others, Angie is member of our closed and free Facebook group TRT and Hormone Optimization Therapy HOT. And if you're watching this, you surely must be interested. And if you haven't already, please join that group. The link you will find under this video. Of course, all men's issues will be addressed in my TOT Doctors Roundtable series, but in this podcast, we will discuss only women's hormones. So, okay, let's start. Welcome, Angie. How are you?
Please like and subscribe. Thank you.
And hit that notification bell so you won't miss anything.
Thank you. I'm doing well. How are you?
So we agreed today to start off with the very basics of female hormones. So I know there is estrogen, progesterone, and testosterone, and that's all about it. So Angie, maybe start off with explaining to the viewers what these hormones are and what they do exactly.
Sure, I'd be happy to. So estrogen is important for women. It helps to protect our cardiovascular system. It lowers our cholesterol levels. It helps to lower blood pressure. It actually has some antioxidant properties. And premenopausal women have high levels of estradiol naturally. And that's why young women are protected against cardiovascular disease. But as we age, we start to lose our estradiol. And when we do, that's when plaque begins to build up inside of our blood vessels. And we develop cardiovascular disease. It also, estradiol helps to protect us against osteoporosis because it keeps our bone density strong. So as we age, when we lose that, bones become weak and brittle. And it also controls static balance. So when we lose estradiol, our balance is off, we're more likely to fall. And if we do fall because our bones are weak and brittle, then we're more likely to experience a fracture. So it's important for many reasons. It helps with macular degeneration, gum loss, tooth loss, skin elasticity. Of course, most people think about, when you think about losing your estradiol, you think about the menopausal symptoms, hot flashes, vaginal dryness, irritability, and then in younger women, PMS type symptoms, bloating, breast tenderness, those kinds of things. So it plays a big role in women's health overall. And the way that we treat it is very different in someone that's premenopausal versus someone that's postmenopausal. So that's estradiol. Progesterone, it is the one hormone that no woman should be without, no matter what stage of her life she's in. It's a calming, mood stabilizing hormone. It enhances everything that's great about estradiol, and it negates the negative things. So it's the drug of choice to treat PMS. It also is very effective in protection against breast cancer. It's been shown to be as effective as tamoxifen, which is one of the drugs of choice to treat breast cancer. It's also very effective in treating endometriosis. And so also there's things that the cyclic seizures that women sometimes experience that go along with the menstrual cycle, progesterone can help with that. So we need it for all those things. And women that have PCOS, they make less progesterone, which is what increases their risk of miscarriage. So it's very important for women in many ways. Okay, and then you asked me also about testosterone.
Yes, what does that do in women?
Okay, for women, it does pretty much the same thing as it does for men. It helps us to build lean muscle, helps us break down fat, keeps our bones strong. It's a mood enhancer. Of course, everybody associates it with increasing sex drive, and it does that, but it also does so much more. It helps to lower the bad cholesterol, raise your good cholesterol, lowers blood pressure because it's a vasodilator. It opens up blood vessels. It helps with decision making.
Mm-hmm. Okay. And why are women significantly more complicated than men?
That's a good question too. We just have more hormones that we have to to consider balancing. Men are pretty straightforward. Testosterone and DHEA, of course, vitamin D and thyroid. But for women, because thyroid also regulates the menstrual cycle, it's just a very complex process. And then also, not every woman is the same. So we have to factor in, is she premenopausal? Is she postmenopausal? Because you would never want to give estradiol to a woman that is premenopausal. If she's still making her own estrogen, and then you give her estrogen on top of that, then it's just going to be way too much, and she's going to get a lot of symptoms like PMS. So she's not going to be a very happy person if you give her that additional estrogen. So you have to consider where they are. We screen every woman that we see that's premenopausal for PCOS, which is polycystic ovarian syndrome. It is the most common endocrine disorder among reproductive age women. And so it's something that I'm very passionate about, because if it's not caught early, then the long-term health risks are very great. It increases your risk of breast cancer, endometrial cancer, miscarriage, diabetes, because the root cause of PCOS is insulin resistance. And that's another thing that I failed to mention about testosterone. Testosterone also helps to lower our insulin resistance, so it helps decrease our risk of diabetes. A lot of the patients that we see that are diabetic, when we give them testosterone, it helps to lower blood sugars, so oftentimes they can take less of their anti-diabetic medications.
Okay, that's very clear. And how do these hormones change over a month's cycle? Because I realize that changes all the time, probably.
It does. If you measure a woman's hormones every day of the month, as long as she's still menstruating, it's going to be different every day. So in premenopausal women, that's not something that we do, because it would vary every day. But for postmenopausal women, we want to get them, just like with men and testosterone, we want to keep your level nice and steady, every day of the month. Same thing with postmenopausal women. We want to keep levels nice and steady, because we want the protective benefits that each one of these hormones provide for us.
Mm-hmm. I understand. And during that month cycle for premenopausal women, is there anything we should check? For example, testosterone levels, or you
No.
don't know?
And for women with testosterone, if they're premenopausal, then we want their testosterone level to be stable too. It's not going to fluctuate. We want it to be nice and steady every day of the month. But some women that are premenopausal will not need testosterone. If they're still making enough on their own, then they won't. But a lot of times, maybe around 35, that's whenever we start to see the women's testosterone decline, just like we do with men. So we evaluate it, but it's also symptoms. If a woman's not complaining of symptoms of testosterone deficiency, then we're not going to worry so much about that. It's when the symptoms are present that we want to start looking for that.
Okay, I understand. And then in women, there's the most beautiful thing they experience that men don't, and that's pregnancy. So what happens to all these hormones during a woman's pregnancy?
Well, during pregnancy, our progesterone levels are through the roof. And that's why a lot of women report that during pregnancy that they feel great, that they feel better than they have ever felt in their life. It makes you more calm, the progesterone does. And like I said, it prevents miscarriage too. So progesterone levels are really high during pregnancy. Now, once you deliver, the progesterone level tanks. And the women that experience postpartum depression, that's the reason, is because they've been used to having really high levels of progesterone. And when you lose that, then that can cause the depression and cause some real problems. So progesterone is great at treating that, and something that, all women, pregnant women, women that have babies should definitely be aware of.
Okay. And so what happens when a woman gets older? So how do these hormones change, and how does that affect the body and health?
Okay, so as we start to age, the hormones decline. And when the hormones decline, that is what accelerates our physical and mental decline as well. So all the degenerative changes that go along with aging are really brought on by the decline in hormones. So women start to become, like I said earlier, osteoporotic. We start to develop cardiovascular disease because there's a plaque buildup inside of the blood vessels. So we want to, for sure, make sure that we maintain our estradiol levels as we age. Otherwise, we'll become symptomatic and become frail, weak, little old ladies, which is not, what we want to do. We want to try to age as strong and age as healthy as we can. A lot of postmenopausal women will come in and they'll complain of mental fogginess, and that's all remedied by increasing estradiol.
Mm-hmm. And do all these three hormones, testosterone, progesterone, and estrogen, decline at the same rate, at the same time, or does that start at different ages?
Different ages, different women. That's what makes women so difficult to treat. And the only thing that we can predict is really things are going to be unpredictable. So, and as we get closer to the menopausal time, during perimenopause, that is really the ultimate as far as difficulty in treating women, because everything that happens is normal and there's no schedule that we can count on as to how that's going to happen. Every woman experiences it a little bit differently. Some women will breeze through without any problem whatsoever and not have very many symptoms at all, but other women have very extreme difficulty with it.
Mm-hmm. Okay, I know very well what all the low testosterone symptoms in men are, but what kind of symptoms do women present when they come to your practice?
It's pretty much the same symptoms. They will complain of a decrease in muscle mass. They're working out at the gym and they can't gain any muscle. They will complain of not being able to lose visceral body fat, the body that accumulates around the midsection especially. It's fatigue, decrease in mood, decreased interest in sex, and decreased exercise tolerance. So their stamina is, not as it once was. Also, anxiety and depression can be present whenever we are low on testosterone.
Mm-hmm. Okay, so now that we know all that, can you maybe sketch a general picture of how to optimize all that? What hormones do women need at menopause, and what levels, for example? What are we talking about? I have no idea.
Okay, so whenever a woman comes in to see us, we take a complete medical history and we want to know what her main symptoms are, what is the most bothersome symptom that she has, and we start addressing those. We also look at baseline hormone levels. We want to see where they are, and we optimize just like we do for men. However, we do consider the progesterone and the estradiol. So we will begin a dose, and with women, we always want to go low and slow because we want to avoid any negative side effects. Women are very sensitive to testosterone, and just like with men, some are very responsive, and it doesn't take much at all, and then some need more. But we would rather always err on the side of caution and start low and slow to try to avoid the most common side effects of testosterone, which is acne and hair growth. Women don't want to grow a beard. They don't want breakouts. And so if you've been without testosterone for a long period of time, or even, just a few years, when you get the testosterone back, then your body is sensitive to it. And so you might experience more of those side effects in the beginning, but then as your body adjusts and gets accustomed to having it, those side effects will go away. But we also have other things that we can utilize to minimize the side effects.
Mm-hmm. That's for testosterone. Mm-hmm.
Okay, so for progesterone, we want to make sure, and depending on whether they're postmenopausal, premenopausal, but we want to make sure that we have adequate protection to prevent endometrial hyperplasia. That's very important. So for a postmenopausal woman, we want to keep that level greater than 20. We want to make sure that she doesn't experience any spotting or bleeding while she's on estradiol. If that happens, then we would have her stop it. We would increase the progesterone. We have some things that we do and try to help her build her tolerance to that. Because if you get too much thickening of the endometrial lining, then that can lead to endometrial cancer. So we have to be very careful about that. And these are all things that men, we don't have to ever worry about. So it is just more complex, for sure. And then for estradiol, we want to make sure that you get enough estradiol that you get the cardiovascular protection. The literature shows us that a level of 75 to 100 is most cardiovascular protective. So that's where we try to get all of our women, but some women can't really tolerate being at a 75 because of the spotting or bleeding. So, but that's what we would prefer is we want them to have the maximum cardiovascular protection. 90% of women will succumb to heart disease. So we want to try to provide them with all of that protection that we can. And also symptoms. If they continue to report symptoms like vaginal dryness for estradiol, then we may push that level higher to try to alleviate that problem.
Okay.
If a woman complains of irritability and it's not getting better, then we want to bump up the progesterone. So a lot of it is not so much numbers. I mean, there are some numbers that we shoot for just because we know it's protective for bone health and cardiovascular health. But a lot of what we do with women is also symptoms.
Okay, like in men.
Exactly.
Okay. Then a bit of a different question. Is there, like in men, also a decline in normal levels in next generations due to the endocrine disrupting chemicals? And are women less susceptible to these EDCs than men, since most of them are estrogenic anyway? Do you have any idea?
Well, we are just as susceptible to the endocrine disrupting chemicals as men are. And, there's studies out there showing because of the things in our environment and the substances in our food, all the things that we're exposed to, that, it wreaks havoc on our endocrine system too. And so that's why you see, young girls are starting their periods earlier and, there's more prevalence of PCOS and it's more significant because there's various levels and degrees of PCOS. You can have, and part of it also is our sedentary lifestyle. Years ago, everybody was outside running, playing, riding bicycle. People weren't inside on a computer or watching TV or whatever. And so when you have higher activity levels, then symptoms of polycystic ovarian syndrome are decreased. So the more sedentary you are, the more significant the symptoms will be. So, and because of the hormones that are in our food supply, that plays a role too.
Mm-hmm.
So I think we are just as susceptible as men are for the endocrine disrupting chemicals.
Yes, but I understood since most of these EDCs are estrogenic, and estrogen is good for women and not so good for men, since it makes them more infertile, for example. Why is there a difference?
Well, just like with men, I mean, you don't ever want a woman's estrogen to get too high. You can't, even though estrogen is good for us and we have higher levels naturally, you still don't want it to become excessive. Because when it becomes excessive, that's when the endometrial lining becomes thick. You develop endometrial hyperplasia. You develop symptoms of excess, like all of the PMS type symptoms that I talked about, irritability, breast tenderness, bloating, all of those. And we want to try to avoid that.
And you see that happening more and more because of these EDCs. Mm-hmm. Okay. So I remember Dr. Keith Nichols saying women are more susceptible for thyroid hormones than men. Why is that?
Well, thyroid controls ovulation, and so it does a lot more for us, I believe, than it does for men. Most every woman that comes in to see us complains of thyroid symptoms. So fatigue, extreme fatigue, temperature dysregulation. Most women will complain of, cold intolerance. Occasionally it's heat intolerance, but cold intolerance is very common. Also hair loss. women will complain of, after taking a shower, there's a lot of hair in the drain, or brushing their hair and there's hair on their vanity and things. And men don't typically experience those kinds of problems, not like women do. So the fatigue, the hair loss, the temperature dysregulation, almost every woman has that on her paperwork. It's filled out as a complaint. And so normally we'll start women on thyroid right away if they have symptoms. And, we look at levels too. But of course, as you know, the levels, it's a big broad range of what's considered to be normal. And we're looking at an average of a population of older, sick people, and we don't necessarily want to be in that range. We want to be in a range where we feel and function best. And and that's another thing with people with polycystic ovarian syndrome, is they produce less thyroid as well. That's another one of the problems. We produce less thyroid and less progesterone. So when your thyroid levels are lower, it's more difficult to lose weight. It's also, your cholesterol levels will be higher. So we want to make sure that we're doing everything that we can, again, to protect against cardiovascular disease for women.
Okay, thanks a lot. So one more point I wanted to make. As a dermatologist seeing patients every day, I see a lot of women, of course, as well. And as they get older, they also complain towards me a lot of times because of hair loss, because of having these typical flushes. And they always tell me, well, I gained a lot of weight since I became postmenopausal and so on. So out of interest, I ask them a lot, so are you taking anything for that? Are you seeing a doctor because of that? And yeah, 80 to 90% of those women tell me, no, I don't want to take anything for that. So I always ask myself and even them, why? So they never can give me a straight answer, really. So do you experience that as well?
They fear breast cancer. That's probably the main reason that women avoid hormone therapy. And they believe that it causes breast cancer based on a 2002 study that was done. It was the Women's Health Initiative study. It was a major health study looking at the effects of synthetic synthetic estrogen. So they used Premarin in that study, which only contains 12% estradiol, which estradiol is the healthy, forever safe estrogen that our body makes on its own. But they didn't use that. They used Premarin. And so Premarin has 10% or 12% estradiol and a lot of horse estrogens. So the estrogenicity of a horse estrogen is a lot stronger. It's more potent than what the human body can tolerate. So also in the study, there were several arms of the study. They were looking at different things. One of them was about memory, and then one of them was just looking at Premarin alone. And the Premarin alone arm of the study, it did not increase the risk of breast cancer. When Premarin was taken alone, it actually lowered the risk of breast cancer. But the arm of the study where they used Premarin combined with a progestin called medroxyprogesterone acetate, or Provera, probably heard of Prempro. When those two were combined, it increased the risk of breast cancer so much so that they stopped the study prematurely. So what got sent out and the message that was delivered was, oh my gosh, hormones cause cancer. Nobody needs to be on hormones. And at that time, a lot of women were taken off of their hormones by their doctors because they feared hormones. What we should have feared was the combination of Premarin and Provera. But there hasn't been any study to date showing any harm or increased risk of breast cancer using bioidentical estradiol. Anytime that we can replicate what nature gave us, then we're always going to get a better result with fewer side effects. So that's, I think, the big reason that women fear it. And then, of course, if they didn't fear it on their own, when they go to their doctor's going to scare them and make them think either that or that they may experience a blood clot, because that was one problem that also was shown in the Premarin-only arm of that study. But there were problems with that as well, because the population of women that was given Premarin was not an ideal population for an oral estrogen. So they were older women that had been already menopausal for 10 years. Well, if you have gone 10 years without estrogen, then the likelihood that you have plaque built up inside of your blood vessels is really high because you don't have the estrogen to combat that. So if you have plaque already inside your vessels and you give someone a horse estrogen that's really potent, what it can do is it can eat away at that plaque and then eventually it will rupture the plaque. So there were 30 out of 10,000 women in that study that ruptured a plaque. But again, it was a high-risk population to start with. And so that's another reason that they fear it. So it's always better too, and what we should have learned from that is start a woman on estradiol early so that we can prevent that plaque from developing in the first place. So, and they were also overweight and they smoked, some of them. So had it been one less, it would have been clinically insignificant, but it wasn't. And so that's why doctors and oftentimes patients fear it. It's just a misunderstanding really of what that study showed.
Okay, and all that fear is based on only one study, and there was never a meta-analysis done on all the studies that also showed that there was no harm.
Not that I'm aware of. I mean, there's tons of studies that show that there is no harm in bioidentical estradiol. The NIH, they've done tons of studies showing the safety of using estradiol. And that's usually what they use is a 2 milligram estradiol tablet, and it's a bioidentical. But it was the combination of the Prim Pro that was the problem.
Okay, that was very, very interesting. Thank you so much, Angie. So I think that will be enough for today. We have to process a lot now, and we can do a follow-up soon, going more in depth once we understand the basic things. All right?
Sounds
Okay.
good.
So please tell the viewers how they can reach out to you and work with you if they would want to.
Oh, sure. You can find us at tier1hw.com, and you can go to our website and you'll find us there.
Okay, so thank you so much and talk to you next time.
Thank you. See you soon.